for tuning in. We've been really pleased to be able to attract so many people to this webinar, because I know it's been an incredibly stressful time. Endometriosis at the best of times is a stressful and painful condition, and with all the delays in appointments, the delays in surgery we've been having during lockdown, I can only imagine what a lot of you have been going through. So we're hopefully going to be able to talk about endometriosis, how it relates to COVID-19 specifically, and some treatment strategies about how you can cope during lockdown, as well as some aspects coming from fertility as well. I'm just going to introduce our panel now. So first of all, I'm Tom Bainton. I'm the Endometriosis Fellow at Chelsea and Westminster, and have set up this webinar together with Mr. Amer Raza, who's one of our endometriosis surgeons and the Director of Services for Gynaecology. We've got Kate MacLaren, who is a consultant in the assisted conception unit in reproductive medicine and fertility. We have Rebecca Payne, who is our endometriosis specialist nurse, who's joined us quite recently, but is getting on really well and hopefully can give us some very good advice about pain management. And we have Nabeela Mughal, who is the consultant here in microbiology and infectious disease, who can hopefully chat to us about COVID specifically and how it relates to endometriosis. So we were going to start off with Dr. Mughal, who was going to tell us a little bit about COVID. I know we're all learning huge amounts. We're all becoming armchair virologists and armchair epidemiologists over the last few weeks, but I'm sure there's some there that'll be a bit of a refresher and hopefully lots of new information about COVID-19. So Nabeela, take it away.
Thank you, Tom. I'll just share my screen. Brilliant. Hi, thank you. So good evening, everybody, and thank you very much to the panel for inviting me. So my name is Dr. Nabeela Mughal, and I'm an infectious diseases and microbiology consultant based here at Chelsea and Westminster. And this is just a very brief overview. I'm sure a lot of people in the audience feel that they know a lot about COVID-19 because they've been interested and have been keeping up with various media channels to sort of provide that information, and then I'm sure there will be more information which will come out from the various questions that the audience has. So just very much a sort of a basic introduction. You know, a lot of people initially were confused about the fact that we were calling this COVID-19. This is actually the name given to the disease caused by the most recently discovered coronavirus. And actually, I think it's quite important to point out that there is a whole family of coronaviruses. So there is the common coronavirus, which causes a cold. There is a Middle Eastern respiratory syndrome, normally known as MRCOG, and then there is the previously known severe acute respiratory syndrome, SARS-CoV, and COVID-19 is now thought to be due to SARS-CoV-2 because it is very similar. Although there is still a review going on, it's thought to have begun back in Wuhan in China in December 2019, but they are looking at their data to see if there were any earlier reports prior to December 2019.
Nabeela, I'm so sorry to interrupt. We've just had a comment in wanting if we could enlarge the slides. I'm sure some people are viewing it on their phone and it might come up quite small if that's possible.
That's it. That's
yeah, is that better?
Yeah.
Thank you.
Perfect. Okay, lovely. So just going back to how it spread, and I think this is quite important just to see for those individuals at home, but also for us as healthcare workers within the hospital setting. So the two main routes really are the droplet and close contacts are the main route of transmission. They can, from a hospital setting, also be spread through finer droplets, and the incubation we know is usually around 3 to 7 days, but actually can be up to 14 days, which is why we have the 14-day isolation period. This is quite a nice diagram which actually shows what happens. So the reason for the sort of kill it, bin it, and keep safe campaign with regards to sort of tissues is that if you have, if you are coryzal with sort of influenza-like illness or COVID-19 illness, then essentially the droplets that you generate, for the yuck factor, unfortunately, those sort of mucus, large droplets that you generate, they are highly infectious. Now, they usually would travel about a metre. But because they are so heavy and so virus filled, they would then fall to the ground, and hence the reason for the 2 metre distancing to prevent those droplets, those highly infectious droplets, from reaching individuals. When they fall to the ground, they can remain infectious for quite a while. We know that on different surfaces, the virus can survive for different rates, depending obviously on how what that surface is like and how much the virus itself desiccates. So essentially 72 hours is what's thought to be a rough survival on most surfaces, which is why it's then very, very important for us to be, as individuals, both in the community and as healthcare professionals, to be washing our hands. So the two direct ways, as I said, are the large droplets, which can travel about 1 meter, highly infectious, but which then fall to the ground and survive for 72 hours. And then those need to be washed off our hands and certainly washed and cleaned off any surfaces that they may have fallen into. Now, in a hospital setting, there are the much finer droplets, which are smaller but less infectious. And because they are smaller, they can travel further and they can stay airborne for much, much longer. And hence the reason for the personal protective equipment that is worn in a healthcare setting. So the symptoms have varied, but essentially most patients would develop a fever, myalgia, so tiredness is what's being reported by many, and then sort of flu-like illness, which may or may not be accompanied by a dry cough. Some patients go on to then develop a shortness of breath and low oxygen levels, and this usually lasts for a period of about 7 days, and most people would then get better after that onset of symptoms and return slowly back to normal. In some severe cases, which is what we've been seeing in the hospital setting, they can go on to develop breathing problems, so what we term as respiratory failure or acute respiratory distress syndrome, with a viral pneumonia, similar to what you can get with other viruses such as influenza. And that is obviously when we see patients within a hospital setting requiring oxygen. In terms of testing, all patients who are admitted with respiratory symptoms are screened for COVID-19. So we normally do a PCR swab, that's a nose and a throat swab, which we then send to the laboratory for a test. It tells us whether you're positive or whether you're negative, and that is one point in time. We are now screening all patients admitted to hospital, so those coming in for elective surgery, but also those being admitted with no symptoms, and they get the same test, which is a PCR test for the COVID-19 virus. This is an example of some of the personal protective equipment that you may see in a hospital setting. So we have taken this from our flu poster that we had, but essentially it is the same equipment, as I explained, because the virus is spreading exactly the same way. So you would see, depending on the area that you're visiting within a hospital, nurses or doctors wearing a face mask with gloves and with aprons, or perhaps wearing a slightly different face mask with a blue or white gown covering, and they would also be wearing a shield to their eyes as well as gloves. And that's a very brief introduction from me. As I said, I'm sure there'll be more questions.
Excellent. Yeah, thank you so much. We actually we're going to do our main Q&A towards the end of the session, but there was one question that came in sort of relevant to what you were saying regarding aerosols and droplets, just asking how long we think COVID can live on surfaces at the moment.
Yeah, cool. So as I was saying, we think it's about 72 hours. Most of the modelling has been done on the other coronaviruses, and particularly on the SARS-CoV. So the very, very sort of early published data were sort of saying, you know, up to many hours on soft furnishings, but actually up to, excuse me, a few hours to a few days on harder surfaces. And that would be most different types of material. So again, within a household setting and also within a healthcare setting, the really, really important aspect is hand washing. So no matter what you touch, you know, if you're washing your hands thereafter, you are protecting yourself. And if you're not then placing those hands to your face and mouth, you are protecting yourself, and within the home setting and healthcare setting, you know, wiping down surfaces and sort of, you know, keeping that environment as clean as you can be will reduce the spread, particularly if you have somebody who's coughing and sneezing within the household. Absolutely.
Thank you so much. I think that just highlights for everyone, irrespective of comorbidities, age, etc., that the primary government advice about washing hands, sneezing and coughing into tissues and then immediately disposing of them, reducing the amount of times we cough our face, which I think we're all amazed how often we do when you notice it, is of paramount importance, regardless of what other conditions you might suffer from. I know we're getting a few more questions coming in related to COVID, specifically in its transmission and things. We will come back to that later on, but we're going to move straight on to Mr. Raza now, who again is our endometriosis specialist here at Chelsea and Westminster, and he's going to fill us in a little bit about how endometriosis and the lockdown, or I beg your pardon, how the lockdown may have affected endometriosis, and how specifically COVID might be related to it as well. So thank you ever so much, Mr. Raza.
Thank you very much, Tom, and thank you for everybody who has joined in and registered for this one now. It's a good opportunity for us to share our thoughts with you. Since this whole pandemic started, we were very concerned about endometriosis patients. We know it's a long-term problem. It's a severe disease with pains and very complex problem with multi-speciality involvement. And with COVID thing, it just broke the whole chain of events and care of clinics and cancellation of theaters. So given this problem, we have been very concerned. Coming first to, does COVID is harmful or more dangerous in endometriosis population? And we have no direct evidence as such that someone has looked at it, but from the pathology and pathogenesis, what we know, we do not think that endometriosis patients are at any higher risk of COVID issue. Secondly, if any patient gets COVID-19, will they be at high risk of problems? Then no, they will not be suffering with any higher risk than anybody else if they have known endometriosis. The problem we had with endometriosis was not the direct impact of endometriosis, of COVID in endometriosis patient, rather what happened indirectly in terms of cancellation of clinics, cancellation of theaters, cancellation of care, which was going on for all these patients. And this has created absolutely a huge challenge. Since pandemic has started, we have a numerous number of phone calls, emails concerning patients telling us that they have been suffering with this problem and how to then get access to the services. We have since that time issued instructions for GPs how to help their patients in community. We have also sent a letter to all of our patients as well, and also sent to our Instagram that how they should be able to cope with this difficult situation when there's a lockdown and they don't have direct access to clinical services such as medical treatments or even simple things like pain therapies, physiotherapy and sessions. So these indirect things have been exactly a huge challenge. We are now, after about 6 weeks now, getting into this recovery phase gradually, where we are planning that how we should start again to treat our endometriosis patient. And I'll come to that in more detail as we go along. So briefly, we are now slowly starting the alternative planning, how we should cope with it, and how we should help our patients. Thank you, Tom.
Thanks ever so much. I think that that's a very important point, that overall, for the vast majority of patients with endometriosis, there is no increased risk of either contracting or becoming more unwell than you might do otherwise with COVID-19. And actually, to highlight more generally, our endometriosis patients are otherwise young and fit and well women. There are, of course, associated conditions, but generally speaking, endometriosis sufferers don't have huge numbers of comorbidities, mostly associated with age. And the other thing that we know, sadly for me and Mr. Raza, is that COVID-19 tends to be more severe, at least in terms of mortality and things, and severity of disease in men as well. So that is at least something reassuring to be taken away. We'll go down into a little bit more detail about some specific circumstances. We've had a few questions asking, I know, about diaphragmatic and thoracic endometriosis, which is very rare. So we'll talk about that a bit later on. But first of all, we're going to move to Rebecca, who not only is our excellent endometriosis nurse, and one of the factors that makes her such an excellent endometriosis nurse, and something she's very open about, is that she has been a long-standing endometriosis sufferer as well. So she is going to tell us a little bit about her experience in lockdown, you know, whether she's had exacerbations of pain or certainly increases in anxiety and ability to access hospitals, and then go into some detail about alternative pain strategies that she's found helpful and that might be helpful for other people. And then Mr. Raza will be able to help us a little bit talking about hormonal strategies and prescription medications after that. So Rebecca, thank you so much for joining us.
Thank you. I've actually been quite lucky in that a few weeks before this happened, I had a surgery but before that I was waiting for a few months, and so I do have experience of waiting for having treatment but there being a delay, and I appreciate how hard that can be when you're in pain and you're suffering. So I'm just going to go through a few things that I found, strategies that are useful for me when I'm having any flare-up of pain. So there's heat pads and heat blankets that I'd recommend, because often I find that heat is more beneficial at times than pain relief. So you could use hot water bottles if that's what you've got, but I would say just be mindful to make sure it's covered, so you're not putting it directly on your skin. I use electric heat pads like this. And they're really great because you can plug them in and you have ones that wrap around your stomach, so you can actually still go about your normal activities like preparing food in the kitchen, but was also receiving some heat to sort of keep it sort of soothed. You can also try, as I know it's getting a bit warmer now as well, using cooling packs, cool packs, and again just make sure they're wrapped before putting them against your stomach. And with these, I think they're good in their own way because they can sort of help numb and soothe, and you can alternate between the two. Another thing that I use that I think is quite useful is TENS machines. This is a bit of an old one because I've had it for so many years, so they're a bit smaller now, but the idea is that you can clip it onto your clothing, and it has these electrodes that you put on your skin, so either sort of around where your stomach, abdo, wherever you get the pain, or your lower back, and it will send little like pulsation electric signals, and the idea is that it should potentially block the pain signals from reaching the brain. Now, regardless of whether it actually does that, I would say for me, I found it's actually just very good as a distraction from the pain, because it's a nice, soothing, repetitive sensation, and it's something that you can just use as and when you need it. So it could be worth a try, and you can get those from pharmacies, supermarkets, things like that. Another thing is in terms of exercise, I think we're going to be talking about this more later, but a simple YouTube search for gentle yoga for endometriosis or pelvic pain comes up with lots of resources that you could use, and that they're more slow, gentle movements that you could follow rather than the more extreme yoga. And with these as well, obviously, if any of it causes you pain, then just stop and rest. Going on from that, there's also things to be aware of what you're wearing. So I know a lot of us wear skinny jeans normally and tight-fitting clothing, but if you're having trouble with abdomen pain and bloating, you're going to find that that's going to cause you more discomfort. So I'd recommend looking at sort of leggings or sort of tracksuit bottoms, those sort of things, just to keep you comfortable in this time. And we're at the benefit of at home, no one has to see you sort of dressed up all smart.
You wouldn't want to see what I got on my bottom half at the moment, Rebecca.
Yeah. Another thing I would talk about is I think with the pain, it can really affect your mental health, and I know I've been there where I found it's really impacted on my well-being, and something that I found beneficial is the use of meditation and mindfulness. There's lots of great resources out there, either online or you can get some apps on your phone these days. It's quite popular at the moment anyway, which is useful. So there's things such as, the one I use is Headspace, and it even has a pain management course you can do, and it gets you to focus in on the pain rather than ignore it and fighting away from it. And I actually found from doing that, it helped me relax into it more and also be aware of where else in my body I wasn't having pain, which was, I felt, beneficial. They also have lots of resources online and on these apps to help with sleep, because I know if you're trying to sleep at night and you've got pain, it's very hard to distract yourself from it. So they have sort of music or sleep casts, wind down exercises to sort of try and shut yourself down and switch off the brain before sleeping. So those are things that I would recommend giving a try. And another thing really is just to be kind to yourself during this time. It's, I know that when you're in pain, there's this sort of tendency that you may try to just keep on going and do everything that you feel you need to do, doing all your chores and pushing. But I think you need to listen to your body. And if you're recognizing you're struggling, then slow down, give yourself some time to rest. And also to tell the people around you, so making sure that someone who you live with knows you're struggling and how they can help you during that time.
Absolutely. I think that's really important, and that's something that you know, we could stress. Just take time for yourself. There's a lot of pressure. You know, people are talking about things on social media about how to improve your life during lockdown and take the opportunity. I think everyone's different. Everyone's got very individual circumstances, and the take time you need for yourself. I think one of the things to take away is that everyone's pain is very different, and people would have found remedies that work well for themselves, and you try and experiment with things that have worked well for you in the past, and see if they can be useful again now. One mention about the heat pads, I know it's something that's concerned a few of our patients in the past, is that when you've used quite a hot pad for a prolonged period of time, it can sometimes cause a rash. It's got a Latin name, erythema ab igne, and it's not dangerous at all. It can be quite concerning. Usually it settles down relatively quickly afterwards, but if you've used a heat pad for a very long period of time where it has been quite hot, it can actually sometimes leave permanent pigmentation. So that's something to be aware of when you're using heat pads. Try and perhaps vary the use, a little bit cooler temperature, slightly less frequently if you're finding any rash coming up. Great, thank you so much, Rebecca. I think sleep as well is something that, you know, we all need to try and take particular care and attention to during lockdown. I know working from home, if you're anything like me, it's tempting to shift the day later and later and set that alarm, a few more snoozers before getting up. So sticking to routine is certainly good for pain management and mental health more generally. We're going to move on to Kate MacLaren now, who's one of our fertility specialists at Chelsea and Westminster. We know that one of the sad features of endometriosis is that it is very strongly associated with subfertility. And on top of that, delays in treatment, whether it be treatment for endometriosis or going on towards fertility treatment, has been known to affect fertility as well. So Kate can give us a little rundown on the implications of the COVID pandemic on the fertility services we're offering here in Chelsea and Westminster, and talk about some strategies and things to move forward to. So take it away, Kate.
Thanks so much, Tom, and thanks everyone for joining us this evening. I thought I'd actually as well give a little bit of a brief update on COVID-19 and pregnancy, for those of you who might be planning pregnancy, and then also just update you on what's happening with the fertility services. So even though we've been asked to stop fertility treatment, at present women haven't been advised that they need to stop trying to conceive naturally, but the guidance says that they should weigh up the risks, which is a bit unclear and unhelpful often for patients. So I thought what I'll try and do is just run through some of those risks and help you understand how to make those decisions. So it's worth noting that it is, as Nabeela said, it is a very new infection, and so we only really have a very limited amount of knowledge about the effects on pregnancy. And the new evidence is sort of continually emerging. However, at the moment, it doesn't seem that pregnant women are any more likely to become infected with the coronavirus than non-pregnant women. And pregnant women who do develop COVID-19 do not appear to be any more likely to get seriously unwell with it. However, it's really important to consider your sort of individual circumstances and your own level of risk if you do have other medical comorbidities, because obviously if you get pregnant, then this is inevitably going to avoid trips up to hospital and more contact with health professionals, and so that may increase your risk of being exposed to the virus. In terms of the actual effects on the pregnancy, the latest evidence does suggest that transmission can occur from a woman to her baby, either during the pregnancy or the birth. But actually, overall, the data so far are really reassuring in that there's no evidence to suggest any increased risk of miscarriage. And it's considered very unlikely that the virus would cause any problems with the baby's development. The latest guidelines from the Royal College of Obstetricians and Gynaecologists report that all newborn babies diagnosed with the virus have so far been well, so it's been very, very reassuring. The main concern is that there have been some reports of preterm delivery in patients with severe COVID-19. However, from these reports, what we can't tell is whether this was directly caused by the virus or whether the premature delivery was needed really to help treat the mother. So there is still some aspects that we don't fully understand. I think if obviously this advice doesn't sort of apply to all of you because many of you may not be considering pregnancy, but if you do want further information on that aspect and how the maternity services have been affected, the RCOG website does have really good patient information on that, particularly regarding antenatal care and delivery and so on. So moving on to the fertility side of things, I suppose it's reasonable to say that for many people who, you know, have had long-standing fertility problems, I think the last few months have just been really, really hard. Many of the emotions that you might have dealt with normally, such as anxiety, isolation, and loss of control, have probably all been exacerbated by this pandemic. And I think from what I've heard from speaking to so many patients that they've been really, really distressed by these delays in the fertility services. But we were really pleased last week to get some positive news finally from the government and the HFEA, the fertility regulars, about restarting treatments. So essentially what we have to do as fertility clinics is put forward to the HFEA our plan about how we're going to reorganise our service, and that's so that we can safely treat patients and really minimise the risk to patients and staff from COVID-19 when they're having the fertility treatment. And so in theory, it might be that clinics can open from around about the middle of this month, so the middle of May, but I think there will be a lot of variability between the different clinics. But certainly at Chelsea, we're really hoping to open services again within the next few weeks. Because of this individual variability, I think it's just really important to be staying in touch with your clinic wherever you are. So certainly at Chelsea, we're updating our website every week. We're running virtual support groups to update people about the services, and most clinics will be offering similar services. So do stay in touch with them, and also remember to have a chat with your fertility specialist or the nurses about what you could be doing in the meantime to really try and maximise your chances of the fertility treatment being successful when it does restart. And I'm happy to sort of talk more about that side of things in the Q&A if we've got time, obviously.
Perfect. Thank you so much. And that's very encouraging news coming from the HFEA regarding the resumption of fertility services. I think a lot of people take positives from that. Just going back to Mr. Raza, talking about pain management strategies, Rebecca had lots of very useful advice regarding accessories and alternative treatments that might be useful, exercise, TENS machine, heat pads, etc. A lot of our patients are currently using hormonal treatments, and we've had a bit of anxiety about how they might be taking them, anxieties about perhaps taking treatments for a little bit longer than they might have originally intended, including GnRH analogues. So I was hoping you could give us a little bit of information about how people can perhaps modify taking their treatment, any sort of rescue therapies people can start with the treatment they're already on at home, to try and reduce the chance of pain flare-ups and needing to come into hospital.
Yeah, thank you. Patients will be in many categories when it comes to endometriosis. Some will be the one who are suffering with pain, have been referred to hospital to be diagnosed with endometriosis, and hence no clinics have been cancelled. So obviously anxiety and stress goes up. For this group of people who have not been formally diagnosed with endometriosis yet, but suffering with the symptoms of endometriosis, it's absolutely the right thing to do to start some kind of hormonal treatment. This hormonal treatment could be in the form of combined oral contraceptive pills or mini pills such as Cerazette. Only thing about combined oral contraceptive pills is that there's a slight high risk of increased blood pressure. That's very uncommon in young and healthy population, but still can be taken safely. And secondly, if you have not your appointment with the hospital, it's absolutely right to contact your GPs. You have access to GPs, and GPs can do a virtual appointment with you, and actually they're easily available to talk to them about the possibility of getting a hormonal treatment like a contraceptive pills or mini pill in this form. Second thing is patients who have been already diagnosed with endometriosis, but now their operations have been cancelled or some investigations have been cancelled, I will expect they will be on some kind of hormonal treatment, either pills or injection Zoladex, as Tom mentioned. Now, whichever treatment you are taking, is absolutely right to carry on with that treatment for some time until the services resume to normality or you're able to get through to those endometriosis centers. As in Chelsea Westminster Hospital, we have a helpline. We're trying to answer patients about their questions. You will, in your own hospitals or local area, will have some kind of helpline or contact number where you can contact them about the resumption of services. But until that time, it's right to continue with the medical treatment you are taking. And concern does come. For example, GnRH analog, mostly in the form of Zoladex, as you will know, or triptorelin injections. If we take them for a long period of time, then anxiety does come. That do they cause vasomotor symptoms, for example, hot flushes, night sweats, or they can lead to osteopenia, weakness of the bones. Again, most patients who are endometriosis, when they take these kind of injections, mostly they are a bridging treatment. If they are waiting for their operation for 3 months or 4 months, they'll be taking that kind of strong medical treatment. And it's absolutely fine to ask your GP or ask your center if they can give you another dose of injection for another 3 months or 6 months. If you use this treatment for 6 to 12 months, it's absolutely safe for you to do so as long as you have spoken to your GP or your clinicians about that. So I think these kind of medical treatment are right. There are other options as well, like Mirena coils or injections. But the problem again will be that face-to-face contact, face-to-face appointment will be less available. But these medical oral treatment are easily available. Your GPs can prescribe them online and you can get them. So these kind of different medical strategies you can use or people can use to help them to get through this period. Yes, thanks, Tom.
Yeah, I think that's important. It's things that have worked before for you, you can probably continue to take. If you've previously been on the combined oral contraceptive pill, you would have previously been screened by your GP or your gynecologist or whoever was prescribing it regarding your risk of blood clots, high blood pressure, migraines, etc. And unless you've developed any new risk factors during the last few months, I think it would be very reasonable to continue to take it. One strategy we talk about in the information we disseminated for our patients locally in Chelsea is the option of taking the pill continuously. A lot of people take the pill for a 21-day period and then have a break where they would expect to have a bleed and might feel that their symptoms get worse during that time. In actual fact, it would be entirely appropriate and wouldn't put you at any particular increased risk to take the pill continuously for a number of months. Eventually, people would find they might have some bleeding. Sorry, Mr. Raza.
And as Tom, just adding to that one, I know there'll be another subgroup of patients in endometriosis with severe disease where they'll be taking some neuropathic medication, like gabapentin, like triptorelin, the amitriptyline. So if you're taking those treatments and waiting for their operation, it's absolutely right for them as well to keep taking these medications until we return to normality or they have access to their clinics.
Absolutely. And we did have a question just going back to that earlier on about whether if you can't access the GP or the pain clinics easy at this time, that you could get a prescription for some of the neuropathic medication like gabapentin, pregabalin or amitriptyline. I think the answer to that is you probably would need a full assessment. They are quite strong medications, usually safe for most people, but certainly it would need to be prescribed by your doctor. So it'd be worth trying to pursue a GP appointment for that. I know that a lot of GPs have moved towards a telephone triage appointment to see whether you need to have a physical appointment, and they can do written prescriptions for that. Mr. Raza, we had a few questions coming in about anxieties taking long-term GnRH analogues. And I think one of our recommendations, am I correct, in that we should certainly add in some estrogen medication if they have been taking it for a prolonged period of time. So we can advise taking a medication called tibolone, which works to mimic the estrogen effect of the ovary, but doesn't increase your pain symptoms of endometriosis to reduce the thinning of bones as well.
Tibolone reference is very good actually, because if you're taking it for 3 months or 4 months and then going for an operation, then possibly most people will not need tibolone and they will carry on. But now if you're saying that they should take it for a longer period of time because they don't have access to operations or clinics yet, then it's absolutely right to ask for tibolone, a good pill which will help them to reduce their vasomotor symptom like hot flushes and night sweats.
Certainly. And we know that GnRH does, of course, have its downsides with the vasomotor symptoms. To put that simply, the effect it's having on your ovaries is to make them appear in a postmenopausal state. So you're not producing the same female sex hormones that you do during reproductive years. It is entirely reversible when the injections have stopped. And the effect that you might find is those symptoms of hot flushes, night sweats, headaches, the sort of changes that you might expect to see in people going through the menopause. The add-back estrogen reduces that effect. Just to go back a little bit, you know, we've talked a lot about strategies that can help avoid coming into hospital. A question I think for Dr. Mughal, would you say that coming into hospital at the moment should be avoided at all costs? Is the risk of becoming infected with COVID-19 in hospital much higher than it is in the community?
Thank you, Tom. So really important questions, and I'm sure a lot of people have asked themselves this. So I think the very, very clear message is that anybody who needs urgent medical attention should be coming into hospital. There are clear pathways for those patients who are likely to have COVID versus those patients who are, you know, coming to hospital with an unrelated COVID-like illness. So I think that message really needs to be stressed. And if you need medical attention, or you know somebody perhaps who's putting off coming into hospital or seeking medical attention, they need to. With regards to the second question, again, there's a lot of anxiety about coming into hospital and what that would mean, and whether you or not you would acquire a COVID. So we, throughout the COVID period, and obviously going into the recovery period going forward, very much are keeping our positive COVID patients on separate wards from our patients who've come in with unrelated COVID-like illnesses. So the risk is very much minimised. Again, the personal protective equipment that is in place in all trusts, but particularly in Chelsea and Westminster, you know, the team have been absolutely fantastic about providing all of our staff with PPE. That is very much in place, and again is there to protect not only staff from acquiring the infection, but also to protect our patients from coming in. So the message would be very clear, and if you need to come into hospital, it is a safe environment. We will do our best to protect those with COVID, but also those without COVID as well.
Thank you so much. That's really helpful and a very important point to make. To that end, although we would perhaps try and avoid hospital for the severe flare-ups of pain with endometriosis, Mr. Raza, are there any particular symptoms that you might suggest patients would absolutely have to come into hospital with? Anything that you really shouldn't be missing?
I think the one thing which I will think of is a severe pain. Severe pain could be a symptom that, yes, we can take simple hormonal treatments and get better analgesics like paracetamol or codadromol. But then again, there could be a situation where the pain can be very severe. So if your pain, you cannot cope with the pain at home, it's absolutely right to come to hospital. And we have a safe places in emergency, separate places in emergency where you can be taken care of. So severe pain, I can think of one thing which people should come in.
Absolutely. Another thing that I think we could mention would be the small risk, but the slightly increased risk with endometriosis, or if you've been trying for a long time to have a baby, of things like ectopic pregnancies. So if you are trying for a baby and you're experiencing severe pain and you know to be pregnant, you've got a positive pregnancy test, then definitely don't defer coming to hospital for that sort of indication as well. Just a few other questions now. We've had quite a few people asking about the risk of thoracic endometriosis, which we know there is a certain prevalence. It's a rare condition, but there's a certain prevalence amongst sufferers with endometriosis. What sort of symptoms would you particularly be worried about in a patient with thoracic endometriosis? And are they at increased risk of infection or becoming unwell with COVID-19?
So we have about 3 to 5% of people who suffer with thoracic endometriosis. And out of these thoracic endometriosis, many will sadly go undiagnosed or will diagnose at a very late stage. And the most common symptom in these patients will be pleuritic chest pain. When they breathe in, they feel a sharp pain. And this sharp pain in many patients actually get worse when they're having their periods. So it's kind of a cyclical change with that period. Obviously, when the thoracic endometriosis increases in its intensity, then it loses cyclical nature, and people have a more continence pain than a cyclical pain. But most people will have a cyclical, sharp chest pain with this one now. With the COVID, it's very unlikely that COVID will make the thoracic endometriosis worse. However, if you have any previous surgery, like thoracotomy, or previous surgery on your diaphragm to remove endometriosis, then there will be some compromise. And I will rather ask you to stay in that high-risk group who should be avoiding going out and rather staying at home and to avoid any contact with any person who has COVID-19.
Absolutely. So if you've had a condition previously affecting the lung, although you're not at increased risk perhaps of contracting COVID, it could potentially make you more unwell. Would it be true, Mr. Raza, that the same hormonal medications that reduce the cyclical pelvic pain would also help with the thoracic pain in those cases?
Yes, absolutely can help as well. To some extent, they will help because the lesions that we have in thoracic, or for that matter, wherever they are, these lesions are controlled with the hormones, and anything we take, like combined pills or other hormonal treatment, will actually stop those receptors to become active and will help with symptoms as well. So taking those hormonal treatment will help to reduce any symptoms.
Perfect. So that's the take-home point, I think. If you've previously been diagnosed or are known to have thoracic or diaphragmatic endometriosis, then continuing to take the hormonal medication should reduce the risk of you becoming unwell during this time. We've got a question coming in for, I think, probably Dr. Mughal and Mr. Raza together, regarding endometriosis is well known to be an inflammatory condition. And a lot of people are reading about sort of autoimmune conditions and chronic inflammatory conditions as putting them at a higher risk of endometriosis. I was wondering, first of all, if Nabeela, you might be able to clarify a little bit about how the inflammation in endometriosis is or is not related to a specific autoimmune condition.
Thank you, Tom. There is a wide variety of various autoimmune conditions, but also non-immune conditions for which various individuals are taking immunosuppressive agents or are immunosuppressed by that underlying condition. And that then puts them at particular risk, not necessarily of severe disease, but possibly more at risk of acquiring COVID-19. And endometriosis is not something at this stage that we are particularly concerned about putting those individuals who suffer from it at increased risk of COVID-19.
Yes, and that's really helpful. So there is undoubtedly an inflammatory element to it. Sorry, Mr. Raza, what are you going to
Yeah, no, absolutely. I concur as well that we don't put endometriosis in that category of inflammatory disease. It is inflammatory, but it's very unlikely that COVID has any relation with it either way to make it worse. So, yes.
Absolutely. Perfect. We've got one question about pain management. You know, we talk about hormonal treatment being helpful, the alternative therapies being helpful, and we've spoken a little bit about neuropathic medication. But we shouldn't forget traditional, simple pain treatment strategies you can get over the counter, such as paracetamol and non-steroidal medications, most commonly ibuprofen. I know there was a little bit of early press about ibuprofen increasing the risk associated with COVID-19. And I was wondering if, Dr. Mughal, perhaps you could clarify whether would you recommend people avoid taking non-steroidal medications at the moment, or is that something you would be confident with people taking at home to manage pain?
It's a good question, Tom. So there isn't, obviously, despite the various concerns initially, there isn't conclusive evidence about non-steroidals putting patients at any more risk if they're taking it in terms of COVID-19. There are various conditions, obviously, that you shouldn't be taking non-steroidals in anyway. So the advice has been to err on the side of caution, but there isn't any conclusive evidence from our various pharmaceutical colleagues.
Sure. So taking to manage symptoms at home if you're otherwise well would be a reasonable strategy. Great. Rebecca, some more questions for you regarding non-medical treatments or non-prescription medication treatments for endometriosis, and particularly regarding diet, and whether you have any suggestions about modifying diet during this time that might help people.
Yeah, so I think the thing is there's no set thing that we can say this works for everybody. Everybody's body behaves differently. But what you can do is try cutting out a particular sort of food type. So for example, I know a lot of people do tend to respond bad to dairy and get maybe IBS-like symptoms with it. So you can try cutting that out, just sort of separate it rather than trying to cut out many things at once, and just spend a bit of time and see if you notice any difference. A lot of people also mentioned that gluten and wheat may be a problem, so that is another thing you can try easing out of your diet at times and see whichever might benefit you, but it is different from person to person.
Yeah, absolutely. I think different people would have found different strategies to work for them in the past. And there is that huge crossover between endometriosis and irritable bowel disease as well, which you might have had advice on separately, either from your GP or one of the gastroenterologists. So I think it's important to heed that advice. And one thing that I think a lot of us might have noticed is alcohol consumption as well. It can change a little bit during lockdown and working from home. So just being aware, perhaps, if you're noticing that being a particular trigger, could be worth trying to cut back on as well.
Yeah, and I can just add to it, Tom, as well, that really this diet thing is very important, especially now when we're locked down, everybody's at home. So it's very tendency to eat more and to take care of the health. And the whole situation causing anxiety and stress actually doesn't help the whole situation with a chronic condition like endometriosis as well. So I think every small problem is feeding into each other. So really very important what Rebecca said before is how to cope with that situation, how to cope with that stress, how to take your mind off from the pain, which absolutely haunts us all the time. So that's very important.
Absolutely. It can be a double-edged sword sometimes regarding eating. Some of you may have noticed, and I noticed a lot of you have voted already. We've got a few polls running in the background. So the first poll was asking, have you had delayed or surgery delayed or cancelled as a result of COVID-19? And a third, bang on 33%, have, sadly. So that's just a reflection of quite how significant it can be in terms of the number of endometriosis patients currently waiting for surgery. A third, I think, is a significant number have been delayed. So keep an eye out for polls. There'll be more coming up as we go along. A question for Kate now, if that's all right. Knowing I have endometriosis, should I be thinking about steps to preserve my fertility, particularly given the delays at the moment? Is there anything patients should be doing or not doing while they're waiting for fertility treatment that would increase their chances of falling pregnant successfully in the future?
Yeah, absolutely, Tom. I think that's a really good question. And as I said before, it's such a frustrating and difficult time for women not being able to go ahead with their fertility treatment. So there are lots of things that you can be doing in this sort of when things are on hold for now. So sort of going on from what you've already been saying. So first, it's a really good opportunity to take a look at your lifestyle and diet. Obviously, this can be really hard during times of stress, but really kind of minimizing smoking and alcohol, eating healthily, and optimizing your weight are all going to be really beneficial. And it's not just for you; it's also really important for sperm quality. So if you have a partner, make sure that he's also doing this. It's a good opportunity to make sure you're taking your folic acid and your vitamin D supplements, because we're not out in the sun much during the social isolation. And again, following on with what we've been saying, I think looking after your mental health is really, really important during this time. So really working to build that kind of strength and resilience and to help you get through the fertility treatment. I've got loads of good resources that I wanted to share with you actually, and I'll try and cut and paste this into the chat box, but there's some really good webinars about how to cope with infertility, particularly in these times of COVID, and Fertility Network have some really helpful things to read as well. And I think it's really important to be asking your clinic if there's anything specific to your case that you can be doing. So, for instance, sometimes women with endometriosis, we quite frequently in our clinic would give them 2 or 3 months of GnRH analogues before their IVF cycle. And for people with low ovarian reserve, again, sometimes we recommend some supplements, antioxidant supplements, and even sometimes some androgens, so testosterone or DHEA, but that's all really sort of on an individual basis, so really important just to try and touch base with your with your specialist. Obviously, when it comes to more formal fertility preservation in terms of endometriosis, really the options for that are egg freezing, or if you have a partner, it's embryo freezing. And so unfortunately, that's all on hold at the minute as well. And we could probably talk for hours about the pros and cons of fertility preservation for endometriosis, and I'm happy to talk about that, but it's probably slightly out with the scope of this webinar. But again, I think if fertility preservation is something you're considering, and we do know that there's an association between endometriosis and low ovarian reserve, particularly in people who have endometriomas. So again, something to consider for the future, and to again really ideally you'd see a fertility specialist who could sort of counsel you and give you your individual kind of risks and benefits for doing something like that.
See, that's really helpful. Thank you. And a lot of you would have noticed that there are people posting in the chat at the moment, posting some resources, and Kate will very kindly put the information there. And one thing to note, she brought up GnRH analogues as being used in treatment or preparation for fertility treatment. So these things are often used for more than one condition. So we can reassure people who are taking GnRH in the context of waiting for surgery for endometriosis, that certainly in and of itself is not damaging fertility, and if anything would be preserving the ovarian function for later. Mr. Raza, and I think a question for Nabeela as well, as we're beginning to think about resuming endometriosis services, patients would have anxieties about coming in for surgery, particularly as we know that the main treatment for endometriosis is laparoscopic surgery, which necessitates a general anaesthetic. Are there any particular increased risks of general anaesthetic in the context of COVID-19 at the moment? Should people be wanting to defer surgery longer, or is it something that we can confidently press on with a very low risk otherwise? I think to Nabeela perhaps first.
Thanks, Tom. So again, a very good question. I mean, I think your risk for a general anaesthetic would be assessed on an individual basis. I think that's the first and foremost thing to point out, about whether that's actually a suitable sort of mode of anaesthetizing for yourself. In terms of elective pathways for patients coming into a hospital setting, again, Mr. Raza and I have been in discussions. So there are very, very clear pathways about how you would come into hospital, how you would be screened in terms of asking about whether you've had any symptoms. You would be offered a COVID-19 swab, and we would wait for the results of that prior to proceeding to any elective procedure, both for this but also for other surgery as well. So again, I think that the risk in terms of general anaesthetic doesn't necessarily predispose you at any more risk to COVID, but would be assessed on an individual basis about whether that would be appropriate for you. But if you then proceed down, coming into hospital for any procedure, it would be very much elective screening for COVID-19, checking whether you have symptoms prior, but also checking on the day and making sure that you were as well as you could be to proceed with the procedure that you need.
Absolutely.
I think Nabeela has answered in a bigger shelf that we are doing everything possible to reduce the risk of patients getting it COVID, or even the staff getting it as well. Now, very specifically laparoscopic, when the COVID-19 came in initially, there was a huge concern and anxiety that is it safe for us to do a laparoscopic surgery, given that we're using a gas in the abdomen, we're using a number of energy resources. But as the time has gone, we are now very confident and going through the process that it is safe to do laparoscopy as long as we have taken all the detailed measures to reduce the risk of transmission. We are using different ports, for example, for laparoscopy. We're using low pressure within the laparoscopy. We are using energy resources where there are no fumes created, which can pass from the patient as well. So we're doing a number of things to make sure that laparoscopic surgery for endometriosis is safe for it to go ahead. And just combining with that, as we are going into the recovery phase, we have made a very strong case in Chelsea Westminster Hospital. And I can see there are many, many people from all over UK who will be either suffering or part of helping groups actually. We have made a strong case in our hospital that when we are coming out of this very difficult phase, we are starting obviously with cancer surgery, cancer operation. No doubt that emergency things like ectopic pregnancy and those things will carry on as well. And when we come to the next group of operations, our patients who should be treated, we believe, is endometriosis patient. These are young patients. They have no comorbidities as such. They are healthy. There's a less need of ITU or NDU beds for this patient. So we have made a strong case to our trust, and I'm very happy to say Chelsea Westminster Hospital now is leading on it to start with endometriosis complex surgery now. That possibly this will be the group of patients we will be able to start operating very soon in 2 to 3 weeks with all those fundamental principles which Dr. Nabeela Mughal has just set in place. What we should do.
Absolutely, and that's really encouraging news for everyone who's been waiting. We can't extrapolate to every hospital in the country, but I know that us here in Chelsea, we've been looking at those patients who would benefit from surgery most in the first stages of getting back into action. So it may be that the waiting list you were on previously might be modified slightly, although I'd expect once the initial cases that really need to be done quite quickly have been dealt with, it would then continue on a basis as when you were previously booked for the operation. So that's really important. It could be as well that with those extra measures, including extra PPE, extra measures intraoperatively, that we aren't able to get through quite as many cases on the same list as we were previously. So although getting going, it might take some time to get through the backlog. So I think all of these strategies to help in terms of delay when you're managing your symptoms will be useful to think about as well. Information just in from another poll. We asked who has had symptoms for or been tested positive for COVID-19. It was 20% of people, which is quite a reasonable amount. So that's interesting to note. I think that's probably higher than the background rate we've been seeing. But of course, we don't know whether everyone has been tested positive. And of course, some of those could have been other conditions, but it may well have been COVID being the predominant virus going around at the moment. Mr. Raza, another question coming in for you, and I think very relevant given that there have been delays in treatment. People asking about different stages of endometriosis, and is one stage necessarily going to progress on to a higher stage? So if someone has been diagnosed with peritoneal endometriosis, will they over time always go on to develop something like a stage 4 deep infiltrating endometriosis?
Yeah, that's a good question. There is no, obviously we know it starts from a mild disease and then goes on to become severe and carries on involving structures from ovaries to fallopian tubes and bowel and ureter. So there's definitely a progression of the disease, but not necessarily that every patient who has a mild endometriosis will go on to get moderate endometriosis, severe, other rectovaginal endometriosis. We still do not understand the complete complexity and the pathogenicity of this disease. But as far as we know, the disease does affect many people in different ways. And the symptoms do not reflect sometimes the severity of the disease inside. We have seen people with a very severe disease inside involving structure, very mild symptom, and people with very mild symptom having a severe disease inside. So there is some element of progression, and hence medical treatment is important for this disease.
Absolutely. And often when we see a patient initially in clinic, our first step isn't to go straight to surgery. What we usually do under most circumstances is use a hormonal treatment to try and optimize things for when the time for the operation comes. So if people, for example, have only just seen a doctor and been booked for surgery, I wouldn't have too much anxiety about an interval of a few months waiting for your definitive operation.
Yeah.
One very interesting question, which I must admit I don't know the answer to, and perhaps Dr. Mughal will be able to help us with, looking at the increased risk of being very unwell from COVID in the male population versus the female population. First of all, do we know why that is? And also, would being on a medication like a GnRH analog, which is suppressing the female sex hormones, put someone at an increased risk in that sense?
Thank you, Tom. I wish I knew the answers. I could make a lot of money. I think it's unfortunately a lot of people are interested in this. A lot of people have observed these differences in terms of the patients presenting both within the community and hospital setting. We don't actually know the answers to that at this stage. And I think it's obviously, it's more than gender as well. People are looking at a lot of different backgrounds and comorbidities to see how those interplay in terms of your response to COVID, but we don't have those answers yet, unfortunately.
Absolutely. I think one reassuring thing in regards to that question about GnRH is that, would I be correct in saying postmenopausally, men are still at a greater risk than women? Most of the women coming to harm from COVID are postmenopausal, who would, in a sense, have the same hormonal profile as someone on a GnRH. So I think it's reassuring in that respect. Perfect. We are rushing through, and actually it's 2 minutes to 7 already. An hour really does whiz by. So I've got to apologise for everyone who's asked really good questions that we haven't had a chance to come to. Lots of good discussion going on in the chat, I can see, and people are very thankfully signposting each other to forums and support networks that they might find useful. I just wanted to thank, in particular, Endometriosis UK for highlighting our webinar on all their social media platforms. I think a lot of you would have heard of us through that, and just asking whereabouts people are from. There's a huge amount of you coming from outside London, and there may even be international people as well. I'm sorry I didn't include that in the poll. So thank you, Endometriosis UK, for raising the profile of this webinar. It's really great we can get out to so many of you and talk about it. I know it's a condition that causes significant stress, significant anxiety. It's an anxious and stressful time for all of us during lockdown with the pandemic going on, and none the more so when you're suffering from a chronic condition and not able to access medical services as easy as possible. So thank you ever so much. And does anyone have any final points they want to add, anything they want to suggest to people?
Yeah, I will just add one point as well. Thank you very much to Endometriosis UK. Organizations like this are doing immensely great work for our community, for our patients. Endometriosis is a very difficult issue. People didn't talk much about it, but thank you to organizations like Endometriosis UK that these issues are coming up into the public. and people are getting more and more information. And I will ask all the patients who are now on this webinar as well, please go onto their website, support them, help them. There's a huge source of information for help as well. So get all the information and take it to them again. Thank you very much for everyone.
And lots of good strategies to donate as well. So thank you, everyone. Thank you, Mr. Raza. Thank you, Kate MacLaren. Thank you, Rebecca. And thank you, Dr. Mughal. This will be recorded and put onto our YouTube channel. That's CCMIG, the Chelsea Centre for Minimally Invasive Gynaecology. Most of, I think, found us through our CCMIG website, and we'll put a link onto the YouTube video there as well. Thank you ever so much. All right.
Thank you very much. Thank you. Thanks very much.
Thank you.